Fine.
Yes, ma'am. Ma'am, after promotion starts, you will launch a poll, ma'am.
Okay.
Ma'am. You can start, ma'am.
Hello, everyone. Dr. Nawal Modi is here again uh, for the ENT topic that we'll be covering. It's tumors of internal, middle, and external ear. So, before we start the topic, I'll just brief you about Auricle, a platform which you can access and use it for your exam preparation. So today's topic will discuss about acoustic neuroma, its signs and symptoms in management and treatment. And in short side, we'll have glomus tumor, periauricular sinus, and if acoustic neuroma is asked for a 4-marker, how you're supposed to answer the question. Now, why to choose Auricle? So Auricle actually is a platform that has recorded classes, live classes, practical sessions, exam modules, and hard copy note sets. So you can access all these together in one platform. This is for all the students. Now, recorded classes, it's like a flexible learning platform where you can access the videos that are recorded anytime to clear off the topic or doubts. It's a platform which is run by an expert instructor. You will have multiple educator contents that you want to study from the recorded classes. Now, live classes will be just like how we are having now. We'll have a question answer session uh, and we'll have a doubt clearing round where students can come up, ask doubts in the comment section. We use last 10 years question papers to conduct live classes and explain you the most repeated questions that will come in the exam. So it's actually an in-depth coverage, and we'll teach you how to write the exam paper, how to present the answer in the exam hall for a particular topic. Now, Express exam module is like a crash course where we cover the entire syllabus in 20 hours. It's like a swift revision before your exam. So if you're done with your reading and if you're done with your practice and learning about the particular topic, then you can, follow this express exam module. It's just like a revision before your exam hall. Now, one-to-one doubt clearing sessions are also there where the students can join in and ask us questions and we clear their doubts, if any, for any topic. It's a very student-centric approach and where we provide tips to the students and we tell the students the important points that are required for the essential topics. Now, we have something called hard copy note sets. Hard copy note sets are like prepared and well wrote notebooks for students who are willing to quit readers and use this. So that it is an in-depth coverage where we use all the past 10 years question papers and we made question answer sessions here. Like how will the question be asked in the exam and how are you supposed to answer it? Points, bullets, diagnosis, and everything is present in the hard copy note sets. Now, Question Bank is a very interesting platform where we have 3 levels from beginners to expert, where you can join this question bank, download it in your Android or your Apple iOS platform, and you can use it, especially students for NEET, PG, and FMGs. They can use this platform to access how the questions might come up. Now, coming to the point of practical sessions, we have practical session trainings where we train students for their practical exams. So it is something that we prepare students. It's very useful for students of final year, students of first year. So they can use this platform to, you know, learn how to present themselves in the practical exam. These are the practical sessions. We have hands-on experience, expert guidance, excellent practical examinations. All right, now coming to the other point that we have here, we have 4 subscription plans: foundation plans, advanced learning plans, complete learning plans, and ultimate plans. So these are the 4 plans that we have. First 2 plans, we do not access the hard copy note sets or one-on-one doubt clearing sets. But the last 2 learning plans, you have a complete access to all the benefits that are provided. And you can use the code NAWALMOHAMMED20 for discount on subscriptions. Now let's move to our topic today. So today's first topic is glomus tumor. But before I explain you glomus tumor, you should know that the tumors of middle ear and mastoid are divided into 2. So I'll write it here that there are 2 tumors, 2 groups of tumors, primary and secondary. Okay, I forgot one thing before this, that before we proceed, we'll have a quiz on your screens. Everyone should solve that quiz and then we'll start for the topic. So let's have our quiz for the day. We have 5 minutes, 1 minute for each question. Okay. Now let's start with our topics. Okay. So first we have classification of tumors of middle ear and mastoid. So middle ear and mastoid. Okay. So there are primary tumors and then there are secondary tumors. Now, every tumor has benign and a malignant stage. So for primary, benign is glomus tumor, that is our topic, and malignant is sarcoma. So benign, glomus tumor. and malignant is sarcoma. All right. So today's topic is glomus tumor. So remember, glomus is a primary benign tumor of middle ear and mastoid. And then coming to the secondary tumor. Secondary tumors are usually in the adjacent areas of nasopharynx, of external meatus, and parotid gland. So it lies somewhere around nasopharynx and external meatus and parotid gland. So secondary can be in nasopharynx, parotid, external meatus. Now, malignant part, the metastatic part of secondary tumors are carcinoma of bronchus, of breast, kidney, thyroid, prostate, GIT, anything. So it's metastatic. Okay. Now, let's know what is the definition of glomus tumor. So it is most common benign neoplasia of the middle ear, and that's why it is named it because of its origin from the glomus bodies. So now glomus tumor is a tumor of middle ear that arises from glomus bodies. Okay. What happens is that if this tumor grows in size, it will start to compress the dome of jugular bulb, or usually on the promontory of the tympanic branch of ninth cranial nerve. So anyways, just for now, remember the tumor of the middle ear that arises from the glomus bodies. That is glomus tumor. Now, what are the etiologies and pathology? So it is usually found in females. Now, the female rate is 5 times more than a male. Okay, it is a benign condition, benign tumor, and it is a very slow and locally invasive tumor. Very slow growing tumor, locally invasive. So now where does it occur? So if this is your ear, it exactly happens in the middle ear, tympanic membrane, ossicles, okay, your cochlea, right? So this is external ear, this is middle ear. So it happens here. This is exactly where the glomus tumor occurs. Okay. Usually happens in the promontory. Now, coming to the other part, when you cut open, let's assume that you have removed the tumor from a patient, right? Now you send it for biopsy for a pathological lab. What will you see when you cut that tumor and you put it under a microscope? You will see that a mass showing sheets of epithelial cells. So microscopically, it will show epithelial cells. All right. And they will have large nuclei and they will have granular cytoplasm. Okay. So microscopically, it is epithelial cells which have large nuclei and granular cytoplasm. So see, this is a middle ear tumor. Middle ear tumor that arises from the glomus body, right? The tumor is derived from neural crest and from paraganglionic cells. So this is exactly where the glomus tumor happens, in the middle ear, right? Paraganglion tumor cells. All right. Now, Before going to clinical features, I just want you to have a brief knowledge or just information that the diagnosis of glomus tumor is to find out which type of glomus tumor it is. So glomus tumor as such is of two types, glomus jugulare and glomus tympanicum. Okay.
Ma'am, hello?
Yes.
Ma'am, we
Yes.
can't see your PPT, ma'am. Suddenly it
You
disappeared.
cannot?
No, ma'am.
Oh my God. Okay. Should I start it again, all over again?
No, no, no. Just in 2 seconds only it disappeared.
Okay. The content of this meeting is being sent to a third party. What is this? Okay. Share. Screen start now. Can you see it now? Visible? Okay. So now there are two types of tumors that everyone should know, glomus tumors. One is glomus jugulare, and the other one is tympanicum. Now, you will have to do diagnosis of a patient with glomus tumor to find out which type of tumor it is. So if it is a glomus jugulare tumor, it means that the tumor arises from the dome of the jugular bone and it will start invading the hypotympanum and the jugular foramen. Okay. So let's assume it's somewhere here, the jugular bulb. Okay. The jugular bulb is here. Jugular vein. So this tumor will arise from the dome of jugular bone, arises from dome of jugular. All right. And it will invade hypotympanum and jugular foramen. Now, what happens is that it may compress jugular vein and it will start causing neurological signs of ninth and 12th cranial nerves. So if it is globus jugulare, it will affect the jugular bulb dome of jugular bulb, and these patients will have neurological signs that will be involving ninth and 12th cranial nerve. So what is ninth and what is 12th cranial nerve? Ninth and 12th cranial nerve. So ninth cranial nerve will be glossopharyngeal nerve and 12th cranial nerve will be hypoglossal nerve. I'll write it. Glossopharyngeal nerve and hypoglossal nerve. All right, hypoglossal nerve and glossopharyngeal nerve. Hypoglossal will be ninth and glossopharyngeal will be 12th cranial nerve. So these patients will have symptoms of dysphagia and inability to swallow, paresthesia of tongue, and all those things. Now, globus tympanicum is another story where it arises from the promontory of the middle ear and it will cause oral symptoms. And sometimes it might cause facial paralysis. So just remember that tympanicum arises from the promontory of middle ear. Okay, so these are two forms of glomus tumor, glomus jugulare and glomus tympanicum. Now, what are the clinical features of this patient? So clinical features are different. Okay, there are three different ways you can find out. Now, when the tumor is in the intratympanicum, the patient's earliest symptom will be hearing loss and tinnitus. Okay, now hearing loss will be conductive type of hearing loss. It's here. Okay, this is the first symptom that will come up. Now, tinnitus will be pulsatile tinnitus, and it will have a swishing character. So, that will be such sound that will happen with pulsation. So, pulsatile and swishing character. Okay, this is tinnitus. Remember, hearing loss is conductive type of hearing loss, and tinnitus is pulsatile and swishing of character. Now, there are two signs that you should remember. When you do an otoscopy of a patient with glomus tumor, you will see that it shows a red reflex through the tympanic membrane. The tympanic membrane here will be intact, but it will show a red reflux. So this is called as rising sign, which is seen when the tumor arises from the floor of the middle ear. So this is the middle ear. Now, if the tumor is arising from the floor of the middle ear, it will be like a rising sun. In early morning, how do you see a sun? Right? So that's how it will look when you see it on otoscopy. And you can think, okay, there's a rising sun sign, and the glomus tumor is arising from the floor of the middle ear. Now, sometimes what happens is that the tympanic membrane will appear blue and it may bulge. Okay, that's a totally different story. But remember that it will look like a rising sun. Then understand that the tumor is arising from the floor. Now, coming to pulsation sign, what is pulsation sign? It is also known as Brown sign. That is when the ear canal pressure is raised. How do we raise ear canal pressure? By using a Sigel speculum. You remember, we have heard about this and we have learned about this in the previous class, that you raise the pressure of the ear by using Sigel speculum. Now, tumor will pulsate vigorously and then it will blanch. Okay. And that when you stop giving the pressure, it will stop pulsating. So that's pulsation sign. Pulsation sign is seen when you increase the pressure of the ear by Sigel speculum. Pressure by Now, if you see rising sun sign, if you see pulsating sign, the patient is having conductive type of hearing loss and tinnitus is showing pulsation and swishing character, then remember that the tumor is intratympanic. Okay. Now, what if the tumor presents as a polyp? So the patients here will also have hearing loss conductive type and they will also have tinnitus, but they will have history and they will complain of bleeding from the ear even if they use a earbud. Okay, so actually when a patient would complain of bleeding when he uses earbud, you should think of a polyp in that case. So here, the tumor, when it becomes a polyp, what will happen is that the patient will have hearing loss and they will have tinnitus, but they will have bleeding from the ear and they will have dizziness, vertigo, and facial paralysis. Dizziness, vertigo, and facial paralysis. Okay. Now, otorrhea may occur when the patient is having infection. So these conditions are usually creating a window for an infection to set in, right? When there is polyp and when there is a tumor, it is creating a window for certain types of infection to set in. So patients may have otorrhea, and this condition may stimulate chronic suppurative otitis media with polyps. So if a patient is having otorrhea, it is a secondary infection. All right. And it can be forming a chronic suppurative otitis media with polyp. All right. Now, when you examine this patient, you will see a red vascular polyp that fills the meatus. Of course, you will see polyp, and when you slowly maneuver it, it will bleed. Okay. Or usually at biopsy, which is not done, but then it will bleed when you maneuver the polyp. Now, this other symptom called cranial nerve palsies. Now, you should understand that glomus tumor doesn't have specific symptoms. The symptoms changes with the position of the tumor, the placement of the tumor. If the tumor is intertympanic, the patient will have rising sun pulsation with hearing loss and tinnitus. Now, if the tumor is becoming a polyp, then it will be bleeding along with dizziness, vertigo, and hearing loss and tinnitus. Right now, when you have cranial nerves involved, It is a very late feature that will happen only after several years of tumor formation. And this tumor is very slow and progressive tumor. So unless and until patient doesn't come into a late stage, later stages means either they will develop polyp and bleed, that's a red flag, or either they will have nerve palsies. So that's only when the patients may present. Other than that, sometimes glomus tumors are only accidental findings. Okay. So when there is cranial nerve palsies, which nerves will be involved? I told you ninth and 12th cranial nerve. So ninth is hypoglossal nerve and 12th is glossopharyngeal nerve. So these patients will have dysphagia, they will have hoarseness, usually unilateral. They will have paralysis of soft palate, right? They will have vocal cord paralysis. Now, vocal cords is ninth cranial nerve, that's vagus nerve. No, vagus nerve is fifth cranial nerve. 10th cranial nerve is vagus nerve. Fifth cranial nerve is trigeminal nerve, right? So with weakness of trapezius and sternocleidomastoid muscle and with atrophy of tongue. Now, atrophy of tongue is because of glossopharyngeal nerve. All right. And sternocleidomastoid muscle is because of 11th cranial nerve. Now, what is 11th cranial nerve? Sternocleidomastoid muscle, accessory nerve. So I'll just write down the nerves here. Soft palate paralysis is because of 9th and 10th cranial nerves. All right. And vocal cord paralysis is because of 10th cranial nerve. That's vagus nerve. Trapezius and sternocleidomastoid muscle. Sternocleidomastoid muscle is because of accessory nerve. That is 11th cranial nerve. And atrophy of tongue is because of 12th cranial nerve. Atrophy of tongue, 12th cranial nerve, right? So the clinical features, if the cranial nerves are involved, will be paralysis in atrophy and weakness of certain muscles. Remember, 9th and 12th cranial nerve will lead to dysphagia, hoarseness of voice, unilateral paralysis of soft palate. Okay, vocal cords if involved, that's vagus nerve. If there is weakness of trapezius and sternocleidomastoid muscle is accessory nerve, that's 11th cranial nerve. And if there is atrophy of tongue, that's 12th cranial nerve, glossopharyngeal nerve. Now, the tumor may present over the mastoid or in the nasopharynx. Now, the signs of intracranial involvement might be seen, but it is very rare. Now, there's something called audible bruit. If you take a stethoscope and you place it over the mastoid bone, this will reveal a systolic bruit. That's what they meant by audible bruit. So if you put a stethoscope over a mastoid, you will hear a systolic bruit. Okay. And some tumors in this condition may secrete catecholamines. These catecholamines will produce symptoms like headache, sweating, palpitation, and hypertension. Remember, catecholamines are the hormones that causes hypertension. For FMGs, it will cause hypertension. There are other tumors also that will secrete catecholamines. But for now, remember that glomus tumor can secrete catecholamines and it might lead to symptoms of hypertension, anxiety, sweating, diaphoresis, palpitation, and headache. Okay, now this will require another set of investigation that you have to do. But remember, audible bruit is when you hear a systolic bruit over mastoid. All right. So these are the symptoms of clinical features, say it, or symptoms, say it, for glomus tumor. You have to write all these points, even if they ask it for a 4 mark. It's an intratympanic, it has different symptoms. If it is tumor as a polyp, it has different symptoms. Cranial nerve involvement will have different symptoms. Audible bruit is also one symptom. Now, rules of TENS is just an information that everyone should know. That it has 10% of tumors that are familial, genetical history, 10% are multicentric, that they will be seen in more than one site. Okay, sometimes since we are studying ENT, the glomus tumor is in the middle ear. The glomus tumor will be found on the edge of the fingers also in infants and children. So that's a totally different set of topic. So glomus tumors are found on the edge of the nails, nail beds, and some other sites are also involved. Now, 10% of them are functional and they will secrete catecholamines. So this is 10, 10, 10. Remember, 10% familial, 10% multicentric, and 10% alcaticulum, mind-secreting tumors. Now, how will you diagnose the patients with glomus tumor? First of all, you have to do a CT scan head. But before that, I'll tell you that CT and MRI combined together will provide an excellent preoperative guidance. Okay, so best thing you can do is you can compile CT head and MRI together. But if not, you can do CT scan of head, where you can easily distinguish between glomus tympanicum from glomus jugulare. Okay, glomus jugulare is the tumor that involves the bulb of the jugular vein, and glomus tympanicum is the tumor that is in the promontory of the middle ear, right? So how will you identify it under the CT scan? If you do the CT scan, you can see something called as corticojugular spine. That corticojugular spine will be eroded. So it will be somewhere here, corticojugular spine. Okay, so this part will be eroded because of the tumor, of course, corticojugular spine, which will be eroded. Okay, so that's what you can see in CT scan. Now, if you do an MRI, what you will see invasion of jugular bulb, if any, or you will see vein compressions, if any, or you can see compression of carotid artery, if any. There's also one test that you can do is 4-vessel angiography. Now, you do 4-vessel angiography when the CT head or MRI shows that there is some sort of compression of carotid artery. So you do a 4-vessel angiography when CT scan shows that the carotid artery is compressed or other vessel structures are compressed. So you do it to see the patency of the vessels. Okay. The other way is you can do a brain perfusion and a flow study. Again, when the tumor pressing the carotid artery, that's when you do it. The best thing you can do is embolization. Now, if the tumors are very large, the embolization of the vessel will help you to shrink the tumor in size, because tumors are usually fed from blood. Okay. Tumors grow in size when they have good blood supply. Even in gynecology, for tumors like fibroids and all, you do an embolization so that you cut off the blood supply to tumor, and after some time, the tumor will shrink in size. The same way in large tumors, embolization of feeding vessels after 1 to 2 days before operation that will help you to reduce the blood loss and also will help you. But 1 to 2 days will not show a lot of difference, right? But you can do an embolization to stop the growth or the compression of the tumor. Now, biopsy should never be done. Remember, biopsy is not a correct answer and it should never be done. Pre-operatively, the biopsy should never be done. You can send the specimen to the pathological lab only after you do a surgery and remove it. Okay? Pre-operative biopsies are never done on glomus tumors. Now, treatment. It consists of surgical procedures and it consists of radiation. Now, surgical procedures, there are a lot of approaches: transcanal approach, not cranial, canal approach, hypotympanic approach, extended facial recess approach, mastoid neck approach, intratemporal fossa approach. Okay, there are a lot of approaches where you do, and there are different reasons for every approach. So if it's a transcanal approach, it is for limited glomus tympanic tumor. Okay, you can do it for glomus tympanic tumor, glomus tympanicum. That is the tumor in the promontory of the middle ear. Now, extended facial recess approach is used for glomus tympanicum procedure again. But the tumor should extend into the mastoid, but not in the jugular bulb. Okay, so facial recess approach is done if the patient again is having glomus tympanicum, but then there are certain indications. What is the indication? It's that the tumor enters in the mastoid, but not jugular bulb. Okay, that is the indication for facial resist approach. Now, hypotympanicum, again, it is for promontory, that is glomus tympanicum, right? So when the tumor extends from promontory into the hypotympanum, but not in the mastoid. Now, again, it has a different indication. So again, this is for glomus tympanicum, but when not in the mastoid. All right. And then we have intratemporal fossa. This is used for glomus jugulare tumors. Okay. Intratemporal glomus jugulare. Rest all three are for glomus tympanicum. But remember, facial recess approach is done when the tumor is in the mastoid, but not affecting the jugular bulb. And hypotympanicum is for glomus tympanicum, but not the mastoid. Okay, remember these differences. Now, radiation. Now, radiation treatment is not the cure of the tumor, but what it will do is that it will stop the vascularity and it will stop the growth. Just like I told you, the tumors are usually fed and they grow in size because of the blood supply. So when you do radiation, it will reduce the vascularity of the tumor and it will arrest its growth. Okay, so radiation is used for tumors which are not operatable. And let's say the patient is in a state where conservative management is not of use, right? Or it is usually in the skull base where you cannot operate the patient. So that's where you do radiation. See, radiations is not used for inoperable tumors, whereas residual tumors, reoccurrence after surgery, or older individuals with extensive skull-based surgeries are not indicated. So you can only do radiation in patients on whom surgery is not indicated. Whereas radiation does not cure the tumor, but it will only stop the vascularity of the tumor and it will stop the growth of the tumor. Remember it in this way. And embolization, on the other hand, also, it is used for diagnosis, but also it reduces the vascularity of the tumor before the surgery. That will help to, decrease the size of the tumor, or at least stop the growth of the tumor, if not decrease the size of the tumor. Okay, so this is about the treatment of glomus tumor. See, embolization. This is how we do embolization. We cut off the blood supply to the tumor, right? And this will stop the growth of the tumor. We have next topic. I hope this topic is very clear and no doubts are there. Now, coming to next topic that we have acoustic neuroma. Now, acoustic neuroma is an essay, an important question. Okay, acoustic neuroma is also known as vestibular schwannoma. Now, why is it known as vestibular schwannoma? So, these are your nerve cells, and they have myelin sheaths. Okay, so these contain Schwann cells. Tumors of these cells are known as schwannomas. Okay, vestibular schwannomas or neurilomas or eighth nerve tumor. So, eighth nerve tumor, vestibular schwannoma or neuroloma. So, eighth nerve is vestibulocochlear nerve. Okay, so it happens here, completely in the inner ear. Let me see the diagram that we have before. Yeah, exactly. So this is where actually the tumor sets in. This is your vestibular nerve, right? And this is your cochlear nerve. So this is exactly where the nerve will set in. Okay, let's go back. Vestibular schwannomas or neurilomas. This is how the acoustic neuroma will look like. So the acoustic neuromas are the tumors that are usually 80% present on cerebellopontine angle. Now, what is cerebellopontine angle? 80% cerebellopontine angle. Now, what is cerebellopontine angle? Let's say this is your brain. Okay, this is cerebellopontine angle, where you have your ninth cranial nerve, that is vestibulocochlear nerve. Here, right. This is vestibulocochlear nerve. So these tumors are usually found here. Okay, cerebellopontine angles. So pathology, the tumor is benign again. It is encapsulated. It is a slow-growing tumor of 8th cranial nerve. Here. Encapsulated, benign, slow-growing tumor involves 8th cranial nerve. Okay. Now, when you cut open this tumor, or when you see it under the microscope, you will see elongated spindle cells with round-shaped nucleus, rod-shaped nucleus. Okay. Microscopically, you will see elongated spindle cells. All right. Now, these tumors can also be bilateral, but bilateral tumors are seen in neurofibromatosis type 2. So make a note of it. This is useful for FMGs, for NEET PGs, all of them. Acoustic neuromas, if they are bilateral, you can suspect that the patient is having neurofibromatosis type 2. Now, you can rule out with the symptoms of neurofibromatosis type 2. That's totally different topic. But just remember that acoustic neuromas, if bilateral, are seen in neurofibromatosis type 2. Okay, you can see here, we have an occipital lobe of the brain, right? We have acoustic neuroma here, compressing the 8th cranial nerve position. It also subcompresses the 4th ventricle, the pons, right? Pushing IAC towards other side cerebellum. Okay, so the tumor arises from the Schwann cells of vestibular part, right? Schwann cells of vestibular, but usually not from cochlear division of. So 8th cranial nerve has 2 divisions, vestibular and cochlear. I showed you in the ear diagram. So usually comes out from vestibular, but rarely from the cochlear part. Okay. So now what happens is that as this tumor expands, it will start eroding the canal and then appears into the cerebellopontine angle, right? It causes displacement of brainstem. It will put the pressure on cerebellum, and that's how it will increase the intracranial tension. It will start increasing the intracranial pressure of the patient. Now, acoustic neuromas, if it is very, very large, the patient might land into coma because of intracranial pressure, right? So it will start displacing all the structures of the brain as it grows in size. Okay. Now, in later stages, it causes displacement of brainstem, pressure on cerebellum, and it will rise the intracranial tension. The growth of the tumor, although, is very, very slow. Okay. Now, how will you classify the tumor? The size of the tumor is the classification of the tumor. It can be intracanalicular, it can be small in size, medium in size, or large in size. Okay, so intracanalicular, not intracellular, intracanalicular. So intracanalicular tumor is confined to the internal auditory canal. Now, size less than 1.5 centimeter, 1.5 to 4 centimeter, or more than 4 centimeters. So now this is how you will understand how large of a tumor is and how small of a tumor is. Okay. Now, clinical features of acoustic neuromas usually seen in age group of 60, not just for 60 years of age, it can be between 40 to 60 years also. Okay, so these patients may have cochleovestibular symptoms. So if your vestibular nerve and cochlear nerve both are together, eight cranial nerves, right? So if both of them are involved in this is the earliest symptoms that will happen when the tumor is still in the intracanalicular part. It will start pressurizing on the cochlear and vestibular nerve fibers on the internal auditory canal. So the patient will have cochleovestibular symptoms. Now, what are the cochleovestibular symptoms? They will have hearing loss. Which type of hearing loss? Sensory neural hearing loss, along with tinnitus. Okay, and they may have uh, imbalance and vertigo. Now, imbalance or vertigo is very rarely seen, but is still there. If the patient is having vestibular symptoms, there is imbalance or there is unsteadiness, but vertigo is very rarely seen. Okay, so cochleovestibular sensory neural hearing loss, usually accompanied by tinnitus. Okay, these patients will have difficulty understanding speech out of proportion to tone of hearing loss. So now, the more you increase your pitch, the less the ability of this patient is to hear because he is having sensory neural hearing loss. Now, if they have cranial nerve involvement, right? Fifth cranial nerve, seventh cranial nerve, eighth cranial nerve, ninth and 10th cranial nerves. Clinical features if they involve the cranial nerve. Now, if it is a fifth cranial nerve, there is reduced corneal sensitivity. So what is fifth cranial nerve? Fifth cranial nerve is a trigeminal nerve. Okay. So if the trigeminal nerve is involved, it will start to reduce the corneal sensitivity and it will lead to paresthesia of the face. Okay. So I'll write it down here. Fifth cranial nerve, trigeminal. Corneal sensitivity will also be affected. All right. Now, if there is seventh nerve involvement, so seventh nerve is the facial nerve, right? So there is hyposthesia of posterior meatal wall. The patient will have loss of taste. There will be reduced lacrimation, right? Loss of taste, reduced lacrimation, and there will be delayed blinking reflex. Okay. So seventh cranial nerve, facial nerve. Now, ninth and 10th cranial nerves. Ninth is glossopharyngeal nerve and 10th is vagus nerve, right? So ninth and 10th cranial nerves will lead to dysphagia, hoarseness due to palatine, pharyngeal and laryngeal muscles. Dysphagia and hoarseness due to pharyngeal and laryngeal muscles paralysis. Okay? So ninth cranial nerve is glossopharyngeal nerve and 10th cranial nerve is 10th cranial nerve is vagus nerve, exactly. Ninth is glossopharyngeal. 10th is vagus. Now, this is a very good way of learning the nerves here and there. So as soon as you see any cranial nerve, you should go back and see which nerve is involved because everyone will forget over the time. So everyone should know which cranial nerve belongs to which number. Okay, so ninth and 10th cranial nerves. No. If there is brainstem involvement. Now, over the time, the tumor, as it grows in size, it will start compressing the brainstem. So if brainstem is involved, then the patient will have ataxia, he will have weakness and numbness of upper and lower limbs, right? And they will have hyperreflexia. Now, these are seen when the long motor and sensory tracts are involved, when the tumor is too large of its size. Now, cerebellar involvement, the pressure symptoms on the cerebellum are seen when there is a large tumor. Now, how can you see if the patient is having cerebellar involvement? You will do a finger nose test. You can ask the patient to close their eyes and touch their nose. If they can do it, Then there is some cerebral involvement there you can see. A knee heel test is that you can ask the patient to use his heel to touch his shin and then to knee. Okay. These are all the tests that you can do, and you can see a patient will have an ataxic gait. So all these are not sensory neural, neurological symptoms that you will see if the patient is having cerebral involvement. Now, in the end, the patient's raised intracranial tension. Now, this is a very late feature where the patient will have headache, will have nausea, vomiting, diplopia. Sixth cranial nerve will be involved. He will have papilloedema. Now, sixth cranial nerve is abducens nerve. Okay. Abducens nerve. Sixth cranial nerve. So the patients will have papilloedema. Okay, they will have blurring of vision. All these things when come up when they have raised intracranial tension. So now remember that the clinical features, cochleovestibular symptoms, when cochlear nerve and vestibular nerve, both of them are involved together. Now cranial nerve involvement, if it is a fifth nerve, what will happen? If it is a seventh nerve, what will happen? Ninth and 10th nerve, what will happen? Brain stem is involved. They will have weakness and numbness of upper and lower limbs. If it is a cerebellar involvement, then you have to make sure by finger nose test, by knee heel test, right? Because all these symptoms will happen when the pressure of the tumor is compressing the cerebellar part of the brain. In the end, the patient might have raised intracranial pressure. If not taken care of early, the patient might also land in the state of coma. Now, how will you investigate these patients? So these patients are investigated. Okay, I'll write down the investigations. The investigations of these patients, the important tests to work up for acoustic neuroma patients are pure tone audiometry, and then you do a speech discrimination score. Okay. Pure tone audiometry, speech discrimination. And there's something called roll over curve. Now, what is roll over curve? This will check the speech clarity at the loudest level of the patient. So if you can ask the patient to listen, and you can induce the loudest sound. So if they have acoustic neuromas, the speech clarity of the sound that they are hearing will decrease at higher volumes. Okay, so that's how you do a roll over curve test. Now there's something called stapedial reflex decay. Now, these are all the definite tests, that important workup that you should do for acoustic neuromas. Apart from CT and all, pure tone audiometry, you should do speech discrimination score, rollover score, and stapedial reflex. Now, what is stapedial reflex? It will help you detect the possible nerve issues that is there in this patient. A loud sound is played, and then what will happen? When you play a loud sound, what will happen to your stapedial muscle? It will contract, right? So that is the normal phenomena, that your stapedial muscle will contract until it hears the loud sound. Now, when you stop that loud sound, what will happen is it will stop the contraction. But that's not the case when the patient is having acoustic neuroma. In case of acoustic neuroma, the stapedial muscles will not stop contracting. Okay, it will keep on contracting. This will indicate a problem with the auditory nerve. Okay, so that's why these patients are not able to hear on the louder side of the volume, right? So stapedial reflex decay, read about it. So you do a stapedial reflex decay. So normally, when you hear the sound, stapedial muscle contracts. And when you stop that sound, stapedial muscle will stop contracting. But when the patient is having acoustic neuroma and the auditory nerve is involved, the stapedial muscle will keep on contracting even after you stop that loud sound. So that's called a stapedial reflex decay test. Okay. The other test that you can do is MRI with contrast, of course. Now, surgery. Of course, that's the only treatment that you can do for this patient. That is the only treatment of choice for this patient. Now, it is indicated according to the size of the tumor, of course, but this tumor is a very slow growing tumor. So you have to operate the patient and you have to remove the tumor. You can either do it by middle cranial fossa approach or by translibranate approach or by rectosigmoid approach. We also say it as suboccipital approach. Okay, I'll write it, rectosigmoid approach. And there is something called combined approach, translibranate suboccipital approach. Okay, combined approach is when you combine this both, translibranate suboccipital approach. Okay, just learn the names of the approach. You do not have to learn the procedures for now. Apart from surgery, you do a radiotherapy. Now, radiotherapy can be conventional, can be X knife or gamma knife surgery, or can be a cyber knife surgery. So, cyber knife surgery is a very improvative robotic surgery, very high of its value. It's worth it, where it uses real-time guidance technology, and it is completely a robotic surgery, a cyber knife procedure. This is the diagram you can see for just information. This is how you do a cyber knife procedure. Okay. Now, X knife or gamma knife surgery, it is a form of stereotactic radiotherapy. Okay. You send the radiations to the tumor, and this will minimize the effect on the surrounding tissue. And it will stop the growth of the tumor as well. Now, some patients might have contraindications to surgeries. So if anyone who is having a contraindication to surgery, you can do an X knife or a gamma knife surgery. A conventional therapy, it is an external beam tumor, but it is not actually used for acoustic neuromas. All right, conventional radiotherapy is not used. It is only the advanced type of radiotherapy that will show some effect in the treatment of acoustic neuromas. Other than that, the best treatment you can do is that you can operate the patient and you can surgically remove the tumor. I hope acoustic neuroma is very, very clear. Just remember the approaches and the types of operation surgical procedures that you do. Now, the brain, the glomus tumor and acoustic neuromas, both of them, they do not have specific treatment symptoms like tinnitus, sinusitis, this and that. You have to remember the symptoms according to the size of the tumor, the place of the tumor. Again, for glomus tumor and acoustic neuromas, both of them have different symptoms, different clinical features with different positions. Like, for example, clinical features when they are involved with the cranial nerves, fifth, ninth, 10th, all these things. So make sure you're very well versed of these clinical features of both the tumors, glomus tumor and acoustic neuromas. Okay, now see this diagram here. When the tumor is small, cranial nerve 8 and 7, right? Now, cranial nerve 5th is involving here. The second diagram, when the tumor is a little bit bigger. Now, when it becomes more bigger, cranial nerve 9, 10, and 12 are involved, right? 9, 10, and 11 are involved. Now, when the tumor becomes larger, it will start compressing the cerebellum. It will start compressing the brainstem. This is when you will have cerebellar symptoms, and the nerves are involved here, right? So the tumor becomes larger. The larger it becomes, the greater nerve involvement it takes in. So remember that when it is a 5th cranial nerve involvement, the tumor usually is roughly about 2.5 centimeter of size. This is just for clinical information that it will be 2.5 centimeter of size. So from here, you can understand, let's say the patient is having the symptoms of 5th cranial nerve, where he is having reduced corneal sensitivity, he's having numbness of face, right? So all these are indicating that there is 5th nerve involvement. Now, when this fifth nerve involvement, you can assume that it is 2.5 centimeter roughly. The tumor is 2.5 centimeter. Now you see here, 2.5 centimeter, matlab it's medium sized tumor, right? So this is how also you can differentiate the size of the tumor up with the symptoms. All right. Now coming to the last topic of the day, we have something called periauricular sinus. So what is a periauricular sinus? It is a small congenital opening on the pit near the front or the top edge of the ear. So you can see it's here, right? Now, this is usually because of incomplete fusion of tissues during fetal development. Okay, it's a congenital problem. So which tissue is usually not fused? It is, which tissue is it? Tubercles. Okay, so when your tubercles are not completely fused, it will lead to periauricular sinus. So now the location, you can write it like this in the exam if you want. Location, helix. Write the definition, then write location, and then write symptoms. It is usually harmless unless and until it becomes infected. If not infected. All right. And how do you treat it if it's infected? Surgery. Okay, it's a very small question that will be asked, 2 markers usually. So periauricular sinus are epithelial tracts. Remember this also, it is epithelial tracts. Okay, and it is because of incomplete fusion of the tissue. Which tissue? Tubercles. Now, if it is repeatedly getting infected, they will have discharge and it will lead to an abscess formation. How will you treat it? Surgical excision of the tract and getting through the sinus will stop the repeated infection. You will have to track the sinus because if you leave the sinus and just treat the infection and the prolonged discharge, it will reoccur again. So you'll have to track the sinus and get rid of it as well. So this is periauricular sinus. Thanks for watching. Hope you like the class.